Welcome to the podcast of the European Society of Anesthesiology and Intensive Care. This industry corner episode is kindly supported by Nihon Kohden. And today I'm your host, Miguel Tavares, an intensive care physician who works in Porto, who has been teaching hemodynamics in our country for years. And I work in Porto in Hospital San Antonio. Today we'll be discussing the topic advancing hemodynamics management and exploring the potential of non-invasive cardiac output monitoring. We have invited Mr. Armin Grieb, a clinical expert responsible for hemodynamics from the German team of Nihon Kohden. Welcome.
Welcome, Mr. Tavares. Nice to meet you. Okay. Now, I'm very happy that we can discuss together about the necessity about hemodynamic monitoring, about the advanced hemodynamic monitoring. It's more than only blood pressure measurement. It means that we can also control and measure cardiac output function and the blood flow. And we both know that this is an important part for in hospitals and for the ICUs. And in the last 30 years, we had made a lot of things to make it easier and make it smarter. And so now my question to you is what is your feeling and what is your impression if you when you talk about advanced hemodynamic monitorings?
Well, I've about 30 years experience in from cardiac surgery to intensive care. As a disclosure, I'm an intensivist who is not an anesthetist. And I do every single kind of hemodynamic monitoring that you can imagine. I perform a lot of echocardiography as a kind of first-line approach. But I strongly believe that education is key to integrate information. You may have the best toys in the planet. If you do not integrate that information, you may evolve into directions that may not be the best for your patients.
Yeah.
I liked your introduction. And if I could go back to you,
Yes, do it.
why should I not rely only on heart rate and blood pressure?
Yeah, but blood pressure is not blood flow. There are two different types of routes. And I see that in the last year, more and more, the more and more importance are in the mean arterial pressure, also in during OR and surgeries and something else. The focus at the moment is the mean arterial pressure. Yeah, it's very important, and we know about the risk when the mean arterial pressure is too low, but it's not an information about the blood flow and not information about the blood circulation. And when the blood pressure is too low, I need the reason for it. And cardiac output measurement could be a solution to understand why is the blood pressure decreasing. Maybe the stroke volume is too low. And on the other side, during OR, you know it as well. Anesthetists like water and fluid. And if the patient have problem, give him fluid, but nobody check is it necessary or not. And for this type, I think it's important to understand how is the condition with the heart. And you talked about that more and more. The echocardiography is in focus, and it was we saw it in the market in the last years that during in ORs and also in ICUs, more and more doctors work with echo, and it's perfect because you get a picture, you see the real life picture, what's going on, but it's only a spotlight and it's not a trend. And I think if you're in an emergent situation when the patient condition goes out of the range, you have not the time to check the situation with the echo. Therefore, an continuous trend monitoring could be helpful. And on the other side, with the continuous monitoring, you can see the changing in a very early stage, so that you can do your treatments uh, before something's happened.
I uh, made a provocative question for
Yes.
obvious reasons. Actually, uh, my belief is that most doctors love arterial blood pressure because it's very easy to measure.
Yeah.
Uh, the issue is that when I look at the circulatory system, uh, the blood pressure is a kind of, particularly MAP, is a kind of mixed variable that represents different things.
Mm.
Uh, diastolic blood pressure in the absence of an AV fistula, aortic regurgitation, some congenital central vessel abnormalities, or bradycardia, usually it's a wonderful sensitive indicator of the vascular tonus or vasoplasia. While pulse pressure, the difference between systolic blood pressure and diastolic blood pressure is directly related to stroke volume
Mm.
in a given moment under a certain set of conditions and drugs that will change over
Yes.
time.
Yes.
The fact is that MAP has been used in registries for 6 decades because it was more resistant to artifacts than the other two pressures. But we tend to put in the same number some entities that are physiologically very, very different. One thing is arterial tonus, and patients need the pressure to maintain the blood flow in organs. And the other thing is cardiac output and stroke volume. So my question for you, and I fully agree with your words, because as I said, this was supposed to be a provocative question.
Yes.
My question for you is, independently of my comments and your comments about echo has a lot of limitations. Not all patients have a good sonographic window to perform echocardiography or have the perfect position to perform echo, and so on and so on and so on. But the issue is, how can we detect in an early stage that the circulation is reaching its limit of physiological compensation when you have a decrease in cardiac output? For example, you may be in the operating room, the patient may be bleeding, or even before starting surgery, when you do the drugs for putting the patient under the effect of anesthesia, the hemodynamic consequences are massive.
Mm.
And how can we think, in your opinion, how can we try to detect in a very early stage that the compensatory mechanisms are going to fail, and after that you have what's familiar, the very inconvenient hypertension?
Mm. Mm. I think what what I mean is that we put both things together to one picture, like a puzzle or a mosaic or something else. So you have the information from the blood pressure, and you have the information from the cardiac output. And if you see the complete picture, so the information is better. And I fully agree with you when you start the induction and you inject the anesthesia drugs, you can see the blood pressure goes down, and you can also see that the cardiac output goes down. But the decreasing of the cardiac output is not so massive like the blood pressure. And this both things could be positive information for the doctor to see, okay, now my drugs work, and he must see that both parameters go back to a stable situation. If not, he knows that he gave too much of his drugs, and he must do or must change his therapy. And these both components, for my opinion, are very important. And this is my question, if it could be a benefit if there would be a non-invasive cardiac output trend measurement method without any additional disposables and without any additional monitors. If it would be able, you can measure it with your normal setup, with your 3-lead ECG, with an blood pressure cuff. You don't need an arterial, with a blood pressure cuff and an SpO2 probe on your finger. Could it be a benefit? It's your normal daily workflow, no more.
It's massive. Actually, this is the reason why we are here today.
Yeah.
About non-invasive monitoring. It takes time to implement technology, to implement monitoring technology. The more sophisticated the technology, the longer it takes. Either you do it preemptively, like in the old days, well, the patient is a cardiac risk patient. He goes to surgery, so he needs to have a pulmonary artery catheter.
Yeah.
Or you don't do it preemptively and you react. But if you react, you need time to implement the technology. The beauty of non-invasive monitoring is that with very simple, easy to implement technology, you can start having deeper information. I strongly pay importance to signs of impending failure of compensation mechanism. And the more they approach the point of no return, the more you get closer to hypertension. It's something much more harmful than people think. When you look at statistics, 5 minutes of hypertension already translate in poor outcomes in cardiac, renal, and cerebral function. So the longer the hypertension, and we have a lot of data for that, the worse. So if we could avoid it, if we could, before the hypertension happens, because the cardiac output is already decreasing, that would be nice.
Yeah.
So the ball is in your park, sir.
Yes, yes. And I will discuss with you about a non-invasive cardiac output trend measurement method without any additional disposables, only measured by your daily routine monitoring. And this kind of measurement has limits. Don't use it in several sepsis patients. Don't use it in and don't trust the values. It's really a trend, because if you need the real value of cardiac output and stroke volume, you always need a calibrated system like pulmonalis catheter or transpulmonary thermodilution. All the non-invasive or minimal invasive cardiac output measurement systems works with calculating with formulas and something else. And this is the same with our system too. But you have a very good trend monitoring. And the idea behind is the pulse wave transit time. We use the R wave from the ECG, and then we count the time, how long the pulse wave needs to the fingertip, and will be detected by the SpO2 probe. And these are milliseconds, and every change of this milliseconds will be detected and give you an information. It's stable, it's increasing, it's decreasing, and this is very smart because a lot of this non or minimal invasive devices calculates about 3 minutes, 5 minutes, 10 minutes. You have not a continuous overview, and this is a beat-to-beat analysis, and you can really see from 1 second to another when there are changing. You can see what's happened if you inject vasoactive drugs. You can see what's happened if you give fluid. You can also see what's happened if you make the passive leg raising. You stand in front of this your normal patient monitor and see what's going on, and this is very, very smart, I think so.
So we are talking about, in a more detailed way, pulse wave transit time.
Yes.
The technology was described maybe 15 years ago.
Yes.
And it's exceedingly sensitive. Data is fascinating.
Yeah.
But at the same time, somehow it never got a lot of attention when compared to other methodologies, at least in Europe.
In Europe,
Issue is, you are valuing the trend thing, but there's more. Maybe there's more than that. The real-time information is something that we need if we are, for example, assessing something as simple as is the patient with responsive or is a patient with responding a fluid responder
yes,
or not, because you need to see the change in stroke volume or in cardiac output when you're just infusing a certain amount of fluid. So you're challenging the system, and you have to have a variable, not blood pressure, not heart rate. You need to have a variable that represents cardiac output or that represents stroke volume. So you need to see the change in the moment. Most times this is done by more invasive systems that rely on the quality of the arterial line curve. If you're able to get the same information non-invasively, this is something really important. So other than the ease of implementation and real-time monitoring, the question that I could ask you is, how important is the difference if the patient has 3 liters or 3.5 liters when compared to the change in cardiac output from 3 liters to 3.5 or 3 liters to 2.5? Because that I believe that the difference or the reaction to our attitudes, it's much more important than the absolute value.
Yeah, right.
So I wouldn't mind to have a technique that was less precise, less accurate, but that could give me information very quickly and reliable in the direction, i.e., if I could see a response on cardiac output or the absence of response of cardiac output, this has two very different meanings and two different directions where to go.
Yeah, that's true. That's really true. And the pulse wave transit time depends on the stroke volume, and so this is the second step, if the stroke volume is good enough, your pulse wave transit time is stable. If the stroke volume or the fluid is too much, the stroke volume, and you infuse, give a new fluid infusion, and nothing's happened. Maybe the stroke volume decreases because it's the overload. It's too big. So you will also see it on with the pulse wave transit time, and these are
That's
the
precisely the issue.
yeah
Knowing the answer, monitoring the answer of the heart and the circulatory system to one attitude, like giving a bolus of fluid, testing the system and getting the answer is, for me, much more important than just the absolute value.
yes
Maybe it's not that important in the ICU or in the middle of the surgery to know if the patient has 3.5 liters when compared to 3 liters.
yeah right
But going from one to the other, that's important.
yeah that's true
Either going up or going down.
yes
So I don't need the technology
yeah
to be precise, but I need the technology to tell me how the system is reacting and how the patient is evolving.
yeah
And
that's
if you
true
can provide that in
yeah
a non-invasive way, that's a major asset,
yeah
at least in my view.
yeah yeah because when we talk about, or we discuss about the clinical application, um, maybe it could be an positive impact in the emergency department. So the patient is a black box, and here it makes absolutely sense to check it with echo to get a picture. And if you see that the cardiac filling is not good enough, you can give him fluid, and then you can control it with the echo again, and then you can start your non-invasive cardiac output measurement to watch, is it a stable condition, or is it increasing, decreasing, and so on. And the same in the OR during fluid and drugs um, um,
Actually, I have a
therapies.
very different, a
Yeah.
slightly different view.
Yeah.
Um, the echo is good to get the picture, it's good to do assessment.
Yeah.
But if you want to test fluid responsiveness with echo, it takes a little bit of time.
Okay.
So you need to do the measurement before, you need to do the measurement. It's more than doable. It's easy, but it takes time.
Mm-hmm.
If you have a system that's easy to implement, that will get that information in the moment, that's faster.
Mm-hmm.
And we could also discuss some limitations of echo in order to calculate cardiac output,
Right.
or to be more precise, to calculate stroke volume.
Yeah.
Because it's doable again, but it also has several shortcomings that need to be taken care of, at least with adequate training, in order to perform that kind of measurements. So the advantage of a non-invasive system could be instant information of change,
Yeah.
more than absolute values. And that's something that I would really value.
Fine. I'm very happy about your positive conclusion. And I thank you very much for this discussion with you, and hope we will see us again.
Well, thank you, everyone, for listening to this episode. The European Society of Anesthesia and Intensive Care releases monthly podcasts on the ESAIC website and various streaming platforms. We hope you will join us for the next one. Thank you very much.